this is going to be kind of the logical next step for everyone who becomes endocrine refractory right off the bat? What if somebody has a long natural history? Maybe they've been on anti-estrogen treatments, multiple in a row for years in some cases. Do they need a ADC right off the bat, or couldn't they just take capecitabine for a while and wait and see?
It's a fair question. I mean, I think that ultimately, once a patient's disease becomes endocrine therapy resistant, they're very likely, and their tumor is HER2-low, they're very likely going to get T-Dxd at some point. It's an effective agent in that setting.
Sure.
Now, to your question of should we be using it up front, or perhaps we should sequence a line of chemotherapy beforehand, I look at this as an opportunity to discuss that with the patient.
Sure.
I think that I have certainly treated patients who, in that setting, even if it's indolent, slow-growing disease, are concerned now that they've exhausted endocrine therapy options and really want to pursue the most effective therapy immediately. Whereas other patients do like the oral nature of capecitabine, having just come off typically oral regimens,
right.
And so forth. So it is a discussion. But that being said, I will say I think we've all been in the scenario where you're treating indolent disease, but at some point it starts to progress, maybe not rapidly, but at a faster pace than it was in the endocrine resistant setting.
Sure.
And so I do still think it's reasonable, even in the low burden setting and fairly slow growing setting after endocrine therapy resistance, to consider T-Dxd as your first cytotoxic line.
So at least it's an option, and a balanced discussion with a patient would be
Absolutely.
appropriate
Yeah.
in that instance. Very helpful.